Hey guys, thanks so much for joining me on the podcast here today. How are you?
Great.
Well, we were talking about this a little bit. I think you need to show people where you're at right now, because I don't think they're going to believe us. But this might be everyone. Go watch this if you're not watching. If you're listening, go see where this background is, because it wins the record for best background, I would say. Where are you exactly?
So we were fortunate enough to be hanging out with the ADA Forsyth crew, and that's number 18 at Pebble Beach. So they put us up in a pretty nice place. Ended up being my backyard for the week, and I thought we'd take this opportunity to just make it a background. Why not?
I love it.
Yeah,
and
it's a lot cooler what we got to discuss, but at the same time, the background helped a lot of those conversations. David was here as well, so we talked about some really cool stuff that we're going to chat about on this podcast too.
I love it. All right, well, let's kick things off. We'll David, we'll start with you. Just this is how the screens are on my computer. Just give everyone a quick background on you. We'll go down the row here, and then we'll talk a little bit about the company, and then I know we have some cool stuff we want to talk about from the dental world here today.
Great. Well, I'm not coming from anywhere near as exciting. I'm coming from conference room 1B in Melville, Long Island at Henry Schein's corporate headquarters. So I'm Dave Kochman. Jared, thanks for having me. Thanks for having us. I lead corporate affairs for the company. For those that don't know, we're the world's largest provider of healthcare solutions to office-based clinicians, dentists, and physicians. It's everything end-to-end from products, equipment, solutions, and services. My background is I'm an attorney. I practiced law for about 14 years. I was a partner at a large firm. Then I was a general counsel of a company, and I joined Henry Schein almost 10 years ago now. And so kind of my team, what we work on is really a broad variety of functions that help support all of Henry Schein's operations, right? So we are in 33 countries, direct operations, and many dozen more through distributors, really helping support every office-based healthcare professional with what they need. We are about 60% dental, 35% medical, and then the rest is our value-added services and solutions. Company's been around since 1932. We're about 26,000 Team Schein members. And we do say Team Schein members, just as dentists and physicians really practice with teams, we think of ourselves as a collective team. And so it is kind of a group effort with everything we do.
I love it.
Cool. So I'm a member of that team. And what's really exciting is that a big branch of that is the software side. So I'm the chief strategy officer and clinical officer for Henry Schein One. We are the largest, not just, obviously we're the software branch of Henry Schein Dental, right? We're a joint venture with Internet Brands. And we are the largest dental software company in the world. We have just over 80,000 clients that utilize us, from the single location practices all the way to the biggest DSOs in the world. And we provide solutions around basically anything you need software wise in your practice and revenue cycle in your practice. So we are all the way from keeping records for your practice, but then also how you file claims, how you make money, how you make sure that money is correct. And we're trying to automate as much of that as possible. So my background prior to this, founded a company called Simplify, which concentrated a lot on the patient experience and payment processing business. I'm an orthodontist as well, so that's where the doctor comes from in my title. But it's just been a blast solving a lot of these problems for the industry, and with the advent of artificial intelligence, and finally having the conversation around how medicine and dentistry are one thing, right? How we're going to put the mouth back in the body. It's a really exciting time, and we're doing as much as we can to make it easy.
So let's continue on that topic that you just said. So how does an integrated dental and medical approach improve outcomes for really all the above, right? Patients, providers, society, healthcare costs, both can take a stab at it.
Sure. Maybe let me start and then kick it over to Ryan to fill in there. Healthcare itself should not have been siloed, but for some reason, a couple hundred years ago, it ended up being built that way. And then our academic structure ended up following that model of inculcating and teaching students in their own little verticals. And as part of that, oral health kind of got put to the side and was a little bit of a stepchild. And I'd say there's some PTSD from that. And dentists themselves, my father's a pediatric dentist, still feel that. That can work from a provider perspective. And if we're only looking at it from a provider perspective, I'm in my lane, I'm going to understand everything in my lane. And if it's not there, then it goes outside. But it's not patient centric. And what really has happened now is a number of megatrends are driving towards more patient-centric care, which ultimately will be better for everyone overall. It's a couple of those things. First is the cost component there, right? It's very expensive for people to go to different doctors and very time consuming for people to do that. So you map in kind of this push towards convenience, right? If you ask folks themselves, where are they willing to pay a little bit more so that they can get something a bit faster? Absolutely. We've all used, quick payment systems on our phones or different websites which we interact with. People just don't have time for that. And we also know that if you have to jump around provider to provider, you're not necessarily getting a holistic look at care. Most disease states themselves aren't solved or addressed by one simple provider. It's kind of a multifaceted structure. So taking a holistic systemic view of care will ultimately provide better outcomes there. I'd say another mega factor that's driving into this is the ability for patients to have more ownership of their individual data, right? A bunch of us have wearables. There's a lot of new technologies we can use to really make care more personalized and precise with less training needed on the provider side. So all of these are coming together, I'd say, to create an environment that is more hospitable than it ever has been to a systemic healthcare approach. And a key element of that certainly is on the technology and EMR side. And I think Ryan can speak to that.
Yeah, and I don't know about any of the other doctors out there, but I still think I have my feelings hurt from the Hangover movie when they said if somebody has a heart attack, you still got to call 911. Right? We take CPR. We've got this. But at the same time, what David said is spot on. I think it's one of those, the patients want this. We are the leading edge, whether we like it or not. I really like it because, and I think most dentists like it because we convinced the population to come see us twice a year because it is better for their health. Like it's better for their oral health. You go see your dentist twice a year. It's funny. I used to work with the opticians and ophthalmologists out there, and they said, "How the heck did you guys pull that off?" Right? Like, who was your marketing specialist that convinced them of that? Well, no matter what happened in the past, we did it. I don't know how often anybody, in this conversation goes and sees their primary care physician. Hopefully you see them once a year. I don't, right? Until my wife tells me I need to go see them. So we're the leading edge. And because of that, we can start utilizing a lot of the technology that we have, like the artificial intelligence, to maybe we weren't trained on a lot of how to interpret these things or what to do afterwards. But because of artificial intelligence, and if we can just help run the right tests, and by the way, get reimbursed for them, we can actually interpret some of this data and move the patient to the right place they need to go. We can be that leading edge of healthcare. And a big help to this is the technology. So we're making a lot of moves with Henry Schein One, obviously, to integrate that directly into our dental PMS solutions like Dentrix to make it easy to collect that data, to make it easy to bill for that, the things that you're going to do out there, and then also understand it, which is probably the most important part, because then I can convey it to the patient and make it easy.
I'm glad you mentioned the patient. So how do patient behaviors, though, influence the effectiveness of this integrated care approach? And I guess what strategies can be used to address those challenges?
Yeah, I mean, if you got the answer to that, right, you should be running for higher office somewhere. Take a step back. The patients are absolutely a key element of it, but let's look at both sides. My visualization is there's 4 key journeys that we have to walk on the provider side before we can actually have an integrated model. And each one is equally important, but we have to walk them. First is scope of practice. Physicians and dentists each themselves have to be able to do those procedures without fear of repercussion, without fear of liability, that they can be covered for that. Second, as Ryan said, they got to be paid for it. There has to be a reimbursement model. It doesn't necessarily need to be the huge revenue generator, but it can't be a loss system there.
Yeah.
You have to look at treating people around disease states itself and make sure that they can get paid for it. Third, you need the infrastructure to work. That includes having access to the right products and equipment, as well as the EMR, point of care testing. That is a massive opportunity that historically has been done on the physician side, you see a lot in IVF clinics. But when you have a patient physically present in your office twice a year, there is no reason that if a dentist can do a mandibular block, that they can't give a vaccine or give, a capillary blood test. A hygienist can do that. So the infrastructure itself has to support it. And then fourth is the behavioral piece. Dentists and physicians, medical and dental, both sides have to see each other as two sides of the same coin, that they're coextensive, and it is about the patient's health, that they see the patient, their care, as really gravitating around that. So those four things have to get solved on the provider side. Your question about what is the patient's role in this, that is a key one. And I would say that we have to build an incentive structure that engages the patients, right? People make choices every single day about what is important to them. For a lot of folks, they care about their healthcare when it's not working for them, right? When their healthcare is affected and when they are in pain, then that's all that matters. When it's not there, then maybe it's not so important. But there's many countries we can look to for analogs for what we could do. I'll give example. This is on the payment side, right? In South Africa. In South Africa, you're required to charge every single patient the same amount. Doesn't matter what disease state they have. No one can be charged a different fee. So what do the providers there do? They give discounts for compliance with behaviors that are known to help reduce costs. So if you're a generally healthy person, there's a set of preventative protocols that we know will help save disease states from turning into acute conditions. If you're someone who has an NCD, well, we also know that there are specific steps that you can take, which will ultimately help to have those disease states be exacerbated. So how do we engage the patients? We need to come up with an incentive structure that ultimately will allow us to get the patients feeling like they are a part of their own care and that it's not something that someone else is doing. We have all of those ingredients there. It's how are we going to put them together?
Yeah, and I agree. I think that the opportunity, one of the things, like I was saying before, we have the patient coming in twice a year. Now, to get more people covered, that's a whole different story, right? Getting things included, Medicaid, Medicare, especially for our seniors, because that's the majority of the people that need a lot of these things. That's a bit of a different conversation that we should definitely have, but probably don't have the time on this podcast. But dentists are already doing things like this, so they're already trying ways to make do a little bit more with one patient. Okay, some doctors are doing Botox, some are doing injectables. We're using that as an example just because it's what they're doing. It's not like they're really enjoying that. They would much rather do more with just straight health applications. But the way that they're doing that is while they're sitting in the chair, they're saying, "Hey, by the way, have you ever thought about this?" We have that ability to do that with other healthcare means. Hey, would you like me to take your A1C? Would you like me to cross-reference that with your probing depths and see if you have a higher likelihood of heart disease? Right? Okay, cool. You're pregnant. Did you know that your perio disease could lead to an increased chance of preeclampsia? Which could increase the chance of stillbirth and other things like that. These are the kind of conversations we need to have, which again, artificial intelligence can help us with, because one, retroactively training a lot of these doctors would be not only expensive, but also just very difficult to get the doctor in on that piece. So we can help on the artificial intelligence side of training. We can redo how they're thinking about education. And David's already engaging with Harvard on a lot of this, which is really exciting, on rethinking that education portion. Because then you get a new crop of doctors coming out that are just thinking like this when they get into the practice. But I think it's entirely possible to do it now. We just, again, the economics have to make sense. Is it really interesting? While we were here talking with the ADA, there's CEOs from Delta Dental and CEOs from United Concordia here. And they said, we would love to offer these plans. Please, tell us about it. But they have to get the employers to adopt the plan, because typically if they change the plan 10 cents, they're starting to look for another plan. So until we actually talk about combining medical and dental, decreasing the overall risk, making people believe that information, which it's absolutely true and proven, right? We can bring down the overall cost of healthcare if we include these two things together, showing that in an economic model and an actual way to feasibly get that out there. That's another piece that we have to get done, because if the plans don't cover it, the doctors aren't going to provide it, and the patients aren't going to hear about it.
You both mentioned this a little while ago in terms of there needs to be some changes to also like how this is going to be, like how some of this will be paid for, right? Can you talk me through maybe what are some of the opportunities that still exist, like to just enhance the current reimbursement model versus, I know everyone always kind of, when they think of payment models, the answer is always to create a new way to pay for it, right? But that is not necessarily an easy task to go through. So like, is there any ways to enhance the current reimbursement structure to make it work a little bit better without having to completely overhaul it?
Yes, kind of. Is the easiest way to say it. So I'll give an example. Dental insurance is more like a coupon, is the easiest way to say it, right? Because there's maximums. Okay. The maximum, by the way, is the exact same as it was when dental insurance was invented, right? Back in the day for the union workers out in Washington. It's literally almost the exact same. I think it was like $2,600 max. Now it's $3,000 on average, somewhere around there. So it's more of a coupon. It doesn't function like true insurance, where in medical insurance, there is no cap. Okay. As the kids would say. So what happens is if you don't have a cap, what we're finding is that a lot of these larger DSOs have found ways to code for specific things, especially like anesthesia, like implants and surgery. So they're starting with those three. Sleep apnea is another one that they're putting in there. And they're finding ways to code medically, which is difficult, which we can, by the way, help with software. They're finding ways to code for that medically first, so it doesn't eat into the maximum that the patient has. And then they'll actually do the coding for the dental side of things. So what happens is the patient ends up walking away with maybe $5,000 of benefit instead of the $3,000 of benefit. So it really takes the innovation of people that have time. And that's what kind of stinks. And what Henry Schein is trying to do here is, the large DSOs of the world have resources to go do that. They have time. They can hire $1 million consultants to go do that. My buddies who have single locations or 3 locations don't have the money to do that. So they're kind of waiting for that trickle down effect to happen, but it's going to. And the way that we can affect that is that we can make coding wizards, where now what we're talking about integrating into Dentrix is that when you go to code for something, we can say, hey, by the way, if you want to code for that medically, here's the reason code you would use, the diagnostic code, and the actual billing code you would use. Because in medical, there's 3 codes you have to use over there, whereas on dental, you have to use 1. It's just a CDT code. So it's one thing to train people on how to do it. And there's courses all over the place to try to train people how to do it, and they could pay a couple $1,000s and go learn it. But again, it takes them self-motivating themselves to do that. And this is not going to happen widely. But with software saying, hey, have you thought about doing this? They might go, well, what is this? Maybe they call us up. We can provide the education, and they're off and running. So that's where I see a lot of that could help.
Yeah. And I think, also, Jared, part of your question is a change management question. How do we ultimately kind of help this elephant dance, to use the Luke Gerstner model, right? And there's not one way to go at this. My visualization in terms of how the change is going to happen is it'll be at the 2 ends of healthcare. All right. On one end, you've got the very high-end healthcare, concierge medicine, people that are into longevity, are really thinking about healthcare deeply, have the ability to pay for this out of their pocket, and they can go and get a concierge medicine practice that wraps everything holistically and bring that all together. And what you're seeing, those trends that are happening there, is holistic systemic care, right? They're bringing in nutritionists, they're bringing in opticians, they're bringing in dentists and the primary care. It's all there in an integrated fashion. On the other end, you've got single payers that are paying for patients that are paying nothing at all. So those payers themselves have every incentive to make sure they have the absolute most efficient practice. And so here in the US, you're talking Medicaid. If you look in other countries, in the UK, you look in other parts of the world where there's a single payer, they're trying to make their dollar stretch as far as possible. And guess what they're doing? They're taking an integrated care approach, and they're bringing oral health and medicine together. So if you just look at where those things are moving, on one end where they have to pay for it, they're bringing care together. And then on the high end, you see that care coming. It eventually will migrate towards the middle, right? Because things that were very expensive will become a little bit cheaper, and then we'll eventually reach the middle. So there's a change management component of this. It absolutely has to fit with the providers and certainly has to be effective at the schooling level, right? Maybe we're teaching these doctors coming out medical and dental separate. Maybe we should have much more collaboration. If you're taught together, you'll practice together. And then on the other side, right, you've got the high end that will help to bleed over and create cost efficiencies, which will allow the broader middle part of the curve to access a more integrated model.
Before we end up wrapping up here, I would like each of you to provide one key takeaway from this conversation today that you would like the audience to really stick with them. Obviously, there's a lot more than one, but if there was one thing from the conversation from both of you that you want them to really kind of think about and potentially even reach out to you about, like, what would that thing be?
It's time. That's where I'll start. It's time. I think that we have for too long said, maybe I don't have to worry about it. Maybe I'll retire before this happens. This is happening, whether we like it or not. And I think we like it. That's the other thing. I think that as dentists, we have wanted for a long time to be considered as part of this medical community. We also are looking for opportunities to expand our treatment portfolio, right? I think everybody is looking for that out there. So this is opportunity. That's the other thing I want to let people know, because sometimes I think that we are very happy with how we get reimbursed versus how traditional MDs get reimbursed as well. So this is not something that we should be scared of anymore. And I think that we can wade into it. We don't have to go in full bore. We don't have to go crazy. We can pick our targets here, but it's our responsibility. We took an oath, just like it wasn't the Hippocratic oath, but it's very similar. We took an oath to be able to treat the overall health and make the overall health of our patients better. And if we're going to do that, now we're discovering new things out there. We're discovering that basically perio health affects your heart. It affects your mind with Alzheimer's. It affects, like I was talking about earlier, preeclampsia, pre-diabetes, diabetes. It's all these leading indicators are there. We've seen the papers now for, David would know better than me, maybe like for 5 or maybe even 10 years while I was in dental school. And we haven't done a lot. We haven't put the rubber to the road. So I think it's time that we can say, look, maybe we can do some salivary assays out there with, or oral biomes. We can work with our insurance partners to get reimbursed for these things. And we can at least provide the information to our patients, because I mean, look, I'm wearing an Aura ring because it tells me my temperature. It tells me how I slept last night. That's a multi-billion-dollar industry. And, I might not be doing the right thing to get better deep sleep, but at least I'm interested in it and I have the information. And that's the exciting part. If we can provide the right information to these patients and say, look, your perio health is bad. If you continue down this road, your heart is going to be unhealthy and you have X% chance of dying from a heart attack or an infection or whatever it might be. This is where it's going to get really interesting, because as we provide this information to our patients, they're going to be better informed. They're going to say yes to more procedures that make them more healthy. And we're going to be able to get a higher treatment plan acceptance at the end of the day. And then we can work with our medical colleagues to see how they play out. And hopefully we can take care of the problem before we see the effect. That's the other thing that's really interesting, because if everything starts with the oral cavity, right, which a majority of it does, then it's our responsibility to take care of that problem, and we got to prevent the effect at the end of the day.
So I'll build off of Ryan's point about it's time. I would say, don't be afraid of change and be a part of the change you want to see in the world, right? I'll use another South African quote that it's always impossible until it's done. Look, no one's written a playbook for how to do this, and it's not a silver bullet. One thing solves everything. How are we going to do this? It's going to be people jumping into the pond, raising their hands, saying, I want to be a part of this. I want to help. You asked how you can help? Give us a call, because we're trying to build a coalition of the willing to do this. Look, we're a public company. What's our incentive to do this? The more people that access healthcare, the more those providers are going to buy. And because we have good share, they're going to buy some of it from us. The upside of this is we're going to have better population health, higher productivity at lower costs. So it's a win-win-win, which really, is just perfect. It fits right with our corporate philosophy. And ultimately, we're in the healthcare game, right? This cannot just be about financial stuff. If it is, you ask people, why do they become a doctor or dentist? One of the top 2 reasons is they want to help people. If it's just about the money, then that's not real healthcare. We're not there, right? Everyone knows that. You're not holding the hand of a patient who's scared because you're getting paid for it. You're doing it because there's an empath piece to it. And so I appreciate you bringing this forward, Jared, because this is a really important conversation. And, I'll just echo Ryan's point. The time is now. Come join us.
Great point to end on. Thank you both for being here today. Really appreciate your time, and everyone go check out what these guys are doing. Really appreciate the time.
Cool. Thanks, Jared.
Thanks for having us.